How's it going, guys? It's 4:25 a.m., January 19th here in Japan. Pass level question for OBGYN for TCK as well as physiology for step 1. Not going to be a lengthy clip, okay? Just quick discussion of why we have the arrows the way we do in pregnancy. I'll elucidate things for you. So before we get started, please subscribe to my channel. Really appreciate it. Give the video a like. Really appreciate it. Find me on Instagram at mehlman_medical, mehlman_medical. Links down below. Find me on Telegram. Links to the Telegram group and channel down below. Now start the clip. 34-year-old woman, G2, P1, 14 weeks gestation. Question just wants to know, what combination of arrows do we expect for TSH, free T4, and total T4? Now, the discussion of the mechanism in this regard can get very fucking complicated very fucking fast. So what I'm going to do is elucidate things by reverse engineering a reverse discussion where I give you the answer first, and then I'll explain why the arrows are the way they are, okay? So our answer is, in pregnancy, this is what you will select on the USMLE if they ask you in an arrow question. You're going to select no change TSH, no change free T4, increased total T4 in pregnancy. Now, the high yield points you need to know. They ask this on the step 1 nbme. They give you a question where TSH is in the normal range and total T4 is increased in a pregnant woman. They don't mention free T4, and they just say, which of the following hormones is most likely responsible for this patient's findings? Increased progesterone? Wrong fucking answer. It's increased estrogen. So what you need to know is estrogen causes the liver to secrete more thyroid-binding globulin, TBG. Now, normally, physiologically, T4, we have 1% that's free, 99% that is protein-bound to TBG. It is the free T4 that exerts the physiologic effect. So as TBG increases, concurrent to increasing estrogen through pregnancy, we have a transient decrease in our free T4. So the hypothalamus and anterior pituitary will sense this transient decrease in free T4 as though the patient is deficient in thyroid hormone and will jack up TSH to compensate. TSH will cause the thyroid gland to produce more T4, which will immediately get bound by more TBG, and this process will ensue until ultimately the absolute amount of serum free T4 is within the normal range. Okay, as I prefaced with, can get very fucking complicated very fucking fast. And as I just said, there is a transient increase in TSH. So student says, what do you mean? Like you just said, it's normal TSH. Right, it's because USMLE doesn't give a fuck about the transient flux of the thyroid hormones as per the mechanism I just described. What they care about is just this. Okay, so when you measure a pregnant woman's thyroid parameters, if she has normal thyroid function, her free T4 will be normal. Okay, it's free T4 that is reflective of definitive thyroid function. So her free T4 will be normal, and because free T4 is normal, TSH will be normal, but we know our total T4 is high because our TBG is high. Okay, so these are the important arrows you need to know. Not a lengthy clip, as I already said, and I'm going to link the high yield arrows PDF below to give you practice with this stuff, as well as the OBGYN PDF if you're on that rotation. You know the deal. I'm going to make more content. If you like my stuff, subscribe to my channel, and I appreciate your time. That's it.